Hey everyone, welcome back to my channel. Thank you so much for clicking on this video. If you're new to my channel, my name is Melissa and I'm a nursing student. And in today's video, I will be taking you through my 12-hour clinical day. So my day starts at 5 in the morning, which sounds really early, but it's actually not that bad because my clinical site this session is about 40 minutes from my house. In the past, I have had clinical sites or hospitals that have been up to 2 hours away from my home, which we have to report to the hospital no later than like 6:30, 6:45. So you can do the math. If I have to get to the hospital at 6:30 and it's 2 hours away, how early I have had to wake up in the past for clinical. So waking up at 5 a.m. on a Saturday sounds awful, but it's not as bad as previous sessions. So I wake up. First thing I do, of course, go to the bathroom, brush my teeth, get ready for my day. Sometimes I put on makeup, sometimes I don't. It just depends on how tired I am. And to make things easier for myself, I always prep the night before. So I will pack my lunch, put it in a lunchbox, put it in the refrigerator, just ready to go. I will prep my clinical bag with my stethoscope and my pens and all of my notes and everything the night before, even my uniform. By Saturday morning, it is washed, it's ironed, and it's folded. So all I have to do is just put it on and get out the house. So I will usually leave the house no later than 5:30, and every single Saturday I have my same routine where I go to Dunkin' Donuts and I get the exact same order. I get a iced coffee, medium iced coffee with caramel swirl, no cream, no sugar. That is my go-to coffee at Dunkin'. And then if I'm feeling hungry, which I usually am not at 5:30 in the morning because it's ridiculously early, I will also get a glazed donut. But usually I don't get the donut, I just get the coffee. And I have found it's kind of like a psychological thing because it's hard to leave the house at 5:30 in the morning. But if I know that I have like my Dunkin' Donuts to look forward to, it gives me an incentive to leave on time. Because if I'm late, then I don't get the luxury of stopping at Dunkin'. So it's kind of like a little mental mind trick that I give myself, something to look forward to so I can get out the house on time. And then when I'm driving to work, I have been listening to music. In the past, I've listened to lectures just because I work full time. It's really hard to get studying in. So anytime that I'm driving in the car, like whether it's to work or to school or to clinical, I'm usually listening to lectures. Since it is 5:30 in the morning and it's hard for my brain to retain any information, I will just listen to music in the car and just kind of zone out. And that's just kind of my time before I start a 12-hour clinical, just to decompress. So by the time I get to the hospital, it's between like 6:15, 6:30. So if I get to the hospital a little bit earlier, I meet up with my cohort or with my other classmates in the lobby. At my school, we're not allowed to go up onto the unit without, one, all of us being there, and two, most importantly, our instructor. So when you get to clinical, you have to wait in the lobby for everybody to arrive and for your clinical instructor to take you up to the unit. So during this time, if I'm feeling antisocial, I will have my earphones in. My cohort is pretty close, which I'm really happy for. So a lot of the time, we'll just kind of talk about class, talk about personal life. If we went out the night before, we'll talk about that. And we just we'll have the moment just to chit chat amongst ourselves and relax and wait for our clinical instructor to get started with the day. So during this time, when I say for our clinical instructor to get started with the day, during this time, we're also kind of given our assignments for the unit. So for my clinical, at least for this session, it's 2 of us paired to 1 nurse. So it's kind of like we're shadowing a nurse for the day. I am not a fan of it because I've been very, very spoiled. I've been spoiled with really, really, really small clinical groups in the past. Once I even had literally a one-on-one where it was just me and my instructor and no other students. And I was in the ICU. It was my first time in the ICU. That by far was my favorite clinical just because a 1-to-1 teacher-student ratio is incredible. And then getting to be in the ICU where I only had 1 patient was just the best experience that I could have asked for. And in the past, even though I've only had 1 clinical like that, most of my clinicals at Chamberlain have been like me, my instructor, and 1 other student, or me, my instructor, and 2 other students. So this session, it's me and 5 other students, so there's 6 of us total. Even though that's still a pretty small, like it's a good sized clinical group, I'm just been spoiled and I'm used to a really small clinical group. So in the past, it's been either me and my instructor or me being paired with one nurse. For this session, it's me, I get a partner, and then we are assigned to the nurse. So it's not too bad, we learn off of each other, but I definitely prefer like the one-to-one student-teacher ratio. So anyway, we are given our assignments. We're not really told too much about our patients. Sometimes we'll kind of be told the underlying condition of our patient, but typically at this time we'll know who our partner is, like what other classmate we're going to be partnered up with. We're going to get the name of the nurse that we'll be shadowing for the day, and then we will get the room number of the patient or the patients that we are shadowing. Right now, my clinical is in the ICU, so the patient ratio at this hospital is 2-to-1. So each week I get 2 patients that I'm going to be taking care of underneath the supervision of my registered nurse. So after we are given our assignments, now it's about 6:40, 6:45-ish, we go up to the unit. So we go up to the unit as a group. We're not allowed to go up by ourselves. And we usually will go to like a break room or the break room, wherever they kind of put us. And we put all of our stuff down. We kind of get our bearings. We get everything together, like our little clipboards and our pens and our stethoscope and everything that we'll need for the unit. And we will take that onto the unit and we will go and meet our nurse for the day. So we introduce ourselves to our nurse. We will usually introduce ourselves pretty much to kind of anybody on the unit. Just like, hi, my name is Melissa. I'm a nursing student. If you need anything, I'm here. If you need me to go to the supply room, I can run and get it for you. Just kind of be friendly and smile and make yourself approachable. That's typically what I do. And then go meet your nurse, introduce yourself. It's really important. Like getting there in the morning is really important because we usually get up on the unit around like 6:45, 6:50-ish. Shift change for most hospitals, I think for all hospitals, at least the one I'm at now, is at 7 a.m. So for shift change, that is when the night shift nurses are going home and the daytime nurses are coming on the unit to take over the patients. And so during shift change, the evening nurse or the night shift nurse will give the day shift nurse report. And so it's really important for us as students to listen to report. And so what most of my clinical instructors do, especially my clinical instructor this session, she is huge on being able to take and give report. So that is like one of the most important parts of my morning. So after we introduce ourselves to our nurse, we meet the night shift nurse, we follow around the day shift nurse and we listen to report as it's given, and we jot down notes on an IS bar or on an S bar so that we know what is going on with our patient. And so for those of you guys that are not familiar with report, pretty much we learn, of course, who our patient is and the patient's name. We learn the mental status of the patient. Is the patient awake? Are they alert? If they are awake and alert, are they confused? Do they know what's going on? Do they know what day it is? Are they in any pain? How much pain are they in? What medications are they being given for pain and for the condition? What their condition is? When did they come to the hospital? Why are they in the hospital? What underlying conditions do they have? What's the family involvement? You know, is the wife involved or the husband involved, the spouse involved? If they're not actually at the bedside, do we need to call and follow up with them? Do we need to call and follow up with the physician? Are there any labs that need to be drawn today? Is the patient going down to surgery? Usually, since I'm at clinical on a Saturday and a Sunday, patients usually are not going down to surgery on the weekends, at least not planned surgery. So all of that is what the night shift nurse is telling us and telling the day shift nurse. And then after we get a run through of everything going on with the patient, which is once we receive report from the night shift nurse, then we actually go into the patient's room. We will meet the patient. We will introduce ourselves to the patient. Mind you, as we are doing all of this as nursing students, we're kind of standing in the background. So the nurse will go in, introduce himself or herself to the patient, and we'll just kind of be standing in the corner politely and wave and be like, hi, I'm Melissa. I'm the student nurse. If you need anything, you can also let me know. Pretty much, you're just kind of there to observe and to learn, and just, I don't want to say to stay out of the way, but you don't want to be in the way too much. You want to be there if they need you, kind of like on standby. So the purpose really is to observe everything the nurse is doing, to get hands-on experience where you can, and then anything that anybody on the unit needs, if they need you to get water, if they need you to fetch like pads, or just anything for patient care, you run to the supply room and you go get it. You're kind of like a gopher, kind of. So after we met with our nurse, after we meet the patient, we got to see the patient and make sure the patient's doing okay, introduce ourselves to the patient. Then we will follow the nurse that we're shadowing, and we'll actually go in and look at the patient's chart. So even though we got a run through from the evening nurse, we went in, we looked at the patient to make sure that the report that we were given matches up with the patient's current status. Then the night shift nurse goes home and we can start our day. And the first thing that we do after we do all of that is then we go into the computer and we look up the patient's chart. So usually the RN will go and do that, and then he or she will let us as students take a look at the chart ourselves, just so we can get experience playing in the chart, seeing what's going on with the patient, looking at the physician's orders, and just getting that hands-on experience of charting. Now I know after all of that, from the time I woke up at 5 in the morning to where we are now, it probably seems like a lot, but in actuality it's only about like 7 a.m., 7:15. So still have the full day ahead of us. One very important thing to do at the beginning of a shift or at the beginning of a clinical is to make sure that you do a full head to toe assessment on a patient so that you know their baseline at the start of your shift. So full head to toe assessment in the hospital means taking off the covers, removing clothing, assessing full body head to toe, the skin, to make sure that there are no wounds. Hospital acquired wounds are such a big thing, and you want to make sure that you prevent them, or if they happen, catch them early. So of course this is going to be up to your nurse. If you are lucky and you have a nurse that allows you to be very hands-on, they will allow you to perform the assessment while of course they are watching you and watching the patient so that they can actually document everything properly. But in the ICU where I'm doing clinicals this session, it is extra important. And I will just take a minute to say, this session I am in the ICU. I've had clinicals in the ICU before. If you are in nursing school and you have not had a clinical in the ICU, or if you've recently graduated and you have not, that is not abnormal. Most of my clinicals have been in med-surg. I think most nursing students will do a majority of their clinicals, if not all, most, because there's also maternity and specialized units. But most of your clinicals as a nursing student will be in med-surg or medical surgical units. I have just gotten really lucky that I have gone to the ICU for a few clinicals. That is not, I think, the norm. I think most nursing students don't do clinicals in the ICU. And I will just say the ICU and med-surg, they're completely different layouts, two very different units. So my clinical days do look very different. On med-surg, it kind of feels almost like I'm a tech, where I will have 5 to 6 patients, or I will be shadowing a nurse that has 5 to 6 patients, and I will be helping with things like doing the vital signs. So it feels like most of my day is just spent rotating around those patients doing vital signs. I will be helping them with their ADLs or their activities of daily living. So helping them order and eventually eat their breakfast, their lunch, and their dinner, helping them brush their teeth, wash their face, get up and like ambulate to the bathroom and things like that. In the ICU, things are different. I will be shadowing a nurse that has only 1 to 2 critically ill patients that are typically, they're not ambulating, they're not alert, they're not oriented, if they're even conscious. So a lot of my day in the ICU really will be, of course, doing a full, very, very thorough head to toe assessment, or watching my nurse do a very, very thorough head to toe assessment, and documenting literally everything. So we will be doing assessments more frequently than in med-surg for each patient, but because there are only 2 patients opposed to 5 or 6, it doesn't feel like my whole day is kind of taken up by that. Another thing is it's very task oriented. So when my nurse is administering medication, a lot of the time I've been lucky and my nurse will kind of run through what the medication is, give me as the nursing student education on why it's being given, and kind of correlating the disease that the patient has or the condition of the patient to the medication and what the medication is actually helping the body do. Most medications are also not given orally, so it's a lot of IV and IV push medications. So there's really not as much education that needs to go on versus in med-surg. Yes, you'll have IV medications, you'll also have oral medications, but a lot of the time you will have a patient who is awake and asking questions like, what is this medication? Why do I need to take it? I don't like this medication. I don't like the side effects. And so I will watch the nurse educate the patient on why it is important, why it needs to be administered, why we're administering it at the time and the way that we are administering it. And it's more collaborative with the patient because the patient is awake and able to give their input. And so education's amazing. I love education. I love listening to my nurse educate the patient because that also helps educate me. That is also very time consuming though. So I don't really have that happening as much in the ICU. Sometimes you'll have a family member that's questioning things, but for the most part, a lot of it is go into the patient's room and you're kind of able to do very thorough, very thorough, head to toe care for the patient. And then you go out and you document that very, very thoroughly. So things are just kind of more structured in the ICU, which for my personality, I definitely prefer. So a lot of my day in the ICU, not totally unexpected, kind of go in once you get the rundown of the patient in the morning. You can kind of map out your day, or the nurse will map out the day for you, and you just kind of follow tasks and times of medication administrations. Not too many crazy things pop up unless there's a code or unless an emergency pops up. Typically the day is very structured, I found in my clinicals in the ICU versus med-surg where anything can pop up. So yeah, the morning is really spent getting to know the patient physically by doing the assessment, administering medication, doing patient care. So if the patient, went to the bathroom, we will clean that up. We will clean the sheets, we'll clean their clothing and their garments. If they have any wounds, we will assist in any way that we can with wound care. Typically that is left to the nurse because you have to be certified to do all of that. Running different medications, all of our medications that we run has to be with our clinical instructor present. So my clinical instructor the whole day, she's kind of going around from each pair because we're put in pairs with our nurse. So she's kind of rotating with each pair, seeing when medications need to be administered, like what time, and then she will kind of pop up when it's time to administer medications and do it with us. So very hands-on, really great. And that takes up our morning. So around like 10:30-ish, we're kind of allowed like a little morning break. It's not like an official break, but if you need to like go to the bathroom, if you need to go back to the break room where our stuff is to get water, maybe get a little bit of a snack, we have like a little 5-10 minutes to do that. So then after my little break in the break room, I'll go back onto the unit and then kind of get like a mini report from my partner and from the nurse in case there were any updates while I was gone of anything that happened with my patient. In the ICU, patients are critical. It's critical care. So it's not like they're stable and the patient's going to crash. Of course, they could be critical and things could get worse, but for the most part, their baseline on that unit is not great to begin with. So if you're leaving for just like 5 minutes or so, anything could happen. But usually when I come back from break, the status is like no updates, or maybe like a family member came and now they're at the bedside, or a family member called and we have to follow up on something. So anything that happened while I was gone, I get the rundown of that and then kind of just continue on the morning doing the same things that we did before my break. So now it's 2 o'clock. We typically take lunch like in the early afternoon. So 2 o'clock is usually around the time that we always go to lunch, and we always go to lunch as a unit. I don't know if it's just my clinical instructor or Chamberlain thing, but we stick together. So when we arrive in the morning, we all have to wait in the lobby so we can go up with our clinical instructor together. When it's lunchtime, we all meet back up in the break room together. We grab our lunch or our money and we all go down to the cafeteria together. Our clinical instructor is like a mama duck, and then we're all like little ducklings that follow her. We're not allowed to just kind of roam around the hospital by ourselves. We're also not allowed to go off campus for lunch. So we all go downstairs, we eat in the cafeteria, and we kind of just decompress. Again, my cohort's really close, so I don't know what other cohorts do, but my cohort, we all eat lunch together. Typically we'll, talk to each other. Sometimes we'll get homework done, like, because we have clinical assignments that we have to do. We have to do like a reflection and a whole lot of paperwork for clinicals. So we'll kind of knock some of that out at lunchtime. And then we kind of use lunchtime as like an unofficial debriefing, going over the different skills and the different cool things that we got to see during the morning. We'll kind of like share that amongst each other. So then after lunch, we all, the same way we went to lunch together, we all go back up to the unit together. We'll put our stuff back in the break room and then we will branch off back to the nurse that we were paired with for the day. So we go back in our groups or our partners, and we get paired back up with the same nurse that we had in the morning. And then again, just the same way as the morning break, when we come back from lunch, we get an update on anything that happened while we were gone. Typically, there's more of an update to give in the afternoon when we get back from lunch, just because in the morning it's only like a 5-minute break, so nothing really happens while you're gone, versus lunch it's a little bit longer. So usually there is an update, especially if like new labs were ordered, a medication came in, family members coming. Usually family will come like in the afternoon. So a lot of the time you come back and someone's at the bedside, or someone needs to be given an education or status update, and the nurse will do that while we're there. So we kind of just get a full rundown of any changes that happened with either of our patients while we were gone at lunchtime. We'll also take this time to look in the chart, see anything new that the nurse has charted. Sometimes we'll actually go in and we will chart as well. It's just kind of like a time to get caught up on anything we missed while we were gone, both with the nurse actually looking at the patient and then also in the chart. And then the afternoon pretty much goes exactly the same as the morning. You know, follow around your nurse, grabbing them anything that they need from the supply room. You are tending to the patient, just helping out in any way that you can. Like I mentioned, more often than not, family will kind of come towards the afternoon. They don't come first thing in the morning, especially if a hospital has visiting hours. But by that time, family will be there. I've also noticed in the ICU, there's not as many visitors as in med-surg. Sometimes in med-surg, I've had like a room full of family, versus the ICU, a patient may get like 1 or 2 loved ones like quietly at the bedside, if even that. I know a lot of hospitals have a maximum of how many people can be in the room in the ICU. Some hospitals only 1 person at a time, some hospitals it's only 2. So you're not gonna have a lot of family, and then you just kind of explain who you are to the family. Hey, I'm the nursing student. If you need anything, please let me know and I will help you, or I can grab the nurse for you. So it's pretty straightforward, and like I said, it's just kind of like a repeat of the morning. So now it is 5 o'clock, so we're getting close to the end of the day, and around 5 o'clock we are allowed like another little 5-minute break if we want to go to the bathroom or go to the break room and have like a nice little snack. By the way, I keep mentioning these little breaks for the bathroom. They're not designated bathroom breaks. If you have to go to the bathroom during clinical, you can just, go. Just, let your nurse know, let somebody know. You don't just walk off on your own. But these are like actual designated breaks. If you just need like a little mental escape to go to the break room and have yourself like a little snack, or to go to the bathroom, usually like my clinical instructor will be like, hey, do you need a minute? Some days I do, some days I don't, especially in the ICU. Some days are more emotionally heavy than others. So it kind of just depends. If the day is kind of chugging along slowly, then I will take my break. Other days things are really, really fast paced and I don't feel like I need a break. More often than not, I don't know if it's because it's like closer to the end of the day, I don't know what, but usually in the afternoon when I go to the break room to have a little snack or something, a lot of times staff will be there just hanging out. And if they're super friendly, I use the opportunity to ask them, so how long have you been a nurse? How long have you been working here? Do you like the work culture on this unit? Just like me being friendly and getting to know the staff, but also me just kind of asking questions to see, like, is this somewhere where I personally would like to apply? And I will say, usually nurses are pretty honest when you ask them questions like that. Like when you ask them, hey, what's the work culture like here? Do you like working here? A lot of nurses will be really eager to tell you, yeah, I love it. It's amazing. It's the best place I've worked. Or they will be blunt and be like, look, this is a paycheck. Do not work here. Management is not great. So I always advise any nursing students, if you're on a unit, if you feel comfortable with the staff, if they're nice to you, just kind of casually get a feel for what the unit is and just ask people, professionally, but just ask them, hey, would you recommend this as a good place for me to start out my career? And 9 times out of 10, the nurses will be honest with you. So if I'm in the break room, I do try to take that opportunity just to get a feel for the work culture while people are having downtime before I go back out on the unit. And then of course, the same way with any break, when you get back on the unit, you need to get a status update of your patient. One thing I've noticed, at least in the ICU, when the nurses, the actual nurses, take breaks, it's a very team-oriented environment, every ICU I've been to. So they'll let another nurse know, hey, I have to go to the bathroom, or I'm taking a little coffee break. Could you please watch my patient? because the patients are so critical. Even if you're gone for 5 minutes, like I said, usually nothing happens, but anything can happen. So you need to make sure somebody has eyes on your patient. So for me as a student, since I have, of course, my nurse and my partner, we don't both take a break at the same time. I let them know that I'm taking my little 5-minute break now. I'm just going to the break room to get some water or something. They will watch the patient. So when I get back, I always get a status update. So it's kind of like practice for the real world, which I really like. So I'll come back onto the unit, get a status update, take a look at the patient's chart, and then finish out the last like hour and a half to 2 hours that I have left. So now we're towards the end of the day. It's around 6:30 at night, and this is when we usually will meet up back at the break room to do our post-conference. At the end of every clinical day, you have something called post-conference where you like huddle around, and for like 30 minutes to 45 minutes, you will discuss different things that happened on the unit. Some days we will gather around 6:30. Some days we'll gather around 7. Once I've even gathered around 7:30. It's supposed to be a 12-hour clinical from like 7 to 7 or 7 to 7:30. But just depending on what's going on the unit and depending on what you get your hands into, sometimes you can run over, which, you know, it happens. But usually around 6:30-ish is when we kind of meet up to grab our stuff and to go somewhere and do our post-conference. Sometimes we do the post-conference in the break room, but a lot of the time we don't want to be in the nurse's way. So a lot of units actually have like a conference room or somewhere for us to go, and so we can do that. And so for this session, my clinical instructor is really, really big on giving and taking report, because she's like, you know, they don't really teach you to do that as much as they should in nursing school, she feels. And she's like, once you get out on the unit, everyone's going to expect you to know how to do this. So at post-conference, the way that we started off this session, every single post-conference, is that we have to give report to either each other or to our clinical instructor about the patients that we just saw. So the patients we just spent all day taking care of, we give report as if our clinical instructor or as if each other or the night shift nurse coming on needing to know how to care for the patient. It is very nerve-wracking, and I don't love doing it, but I will say it's gotten me more comfortable, so now it's not so bad. And I know it's a skill that I need to know how to have, but that's how we always start off post-conference. And then after that, we kind of go around one-on-one and we talk about like our patient, anything we learned that day, anything we found challenging, new things that we got to do. For me, every week I pretty much have done something new in this clinical. A lot of my classmates, this is their first time in the ICU, so like everything is completely new. So our post-conference usually runs over just because the ICU is such a specialized unit that there's kind of a lot to talk about in post-conference. It's not like med-surg where we're mostly doing like ADLs and vitals. In the ICU, when you're doing clinicals, you get to actually see a lot. So post-conference is really cool. You get to hear what other people got to do for the day. You get to talk about what you got to do and just kind of talk through your emotions. If you saw something really emotional, you know, it is the ICU. Unfortunately, not everybody has a good outcome. So we really just kind of use that time to support each other emotionally as well. And now it's around 7:15, 7:30, and it's time to go our separate ways and finally go home after over 12 hours in the hospital. So like I said, my house is like 40 minutes from the hospital, 40-ish minutes from the hospital. So usually I'll get home around like 8:15, like at night on a Saturday night. And first thing I do when I get home is I strip all of my clothes from the hospital because it's disgusting, and I throw them into the wash, and then I myself will get into the shower and just make sure that I'm clean from head to toe. I cannot do anything until my uniform is thrown in the wash and I have gotten into the shower. And then after that, then I can like put on a movie and relax. Since I worked the entire day and I'm exhausted, and by the time I get home and get showered and have dinner, it's already like close to 9 o'clock. So I never have plans on Saturday night. So usually I don't do homework. I'll just like put on a movie or a TV show and watch that for a little bit until I get tired, and then I will go to bed. And that is a full 12-hour clinical day for me. So that is it for this video. Thank you guys so much for watching, especially if you made it to the end. Go ahead and give this video a thumbs up if you enjoyed it, or comment down below if you have any questions. If you have any personal questions for me, I always put my email address in the description box, so you can go ahead and shoot me an email. Thank you guys for watching, and I will see you in my next video.